A very good evening to everyone who have joined today with our online lecture. So today, as you all know, we are dealing with the second lecture in the lecture series on dental implants that is organized by Dentistry, which is the academic arm of the Government Dental Surgeons Association. Last time, we did a lecture on the introductory part into dental implants. And today we have a very interesting topic. That is, we will deep dive into preventing complications of dental implants. Today our lecturer is Dr. Dhanushka Leukebandara. She's a senior lecturer in periodontology attached to the Faculty of Dental Sciences, University of Peradeniya. Thank you very much, madam, for accepting our invitation. And without further ado, I'd like to invite you to go ahead with the lecture.
Yeah, thank you very much, Kemia. Good evening, ladies and gentlemen. Thank you for joining today on a weekday. Now, we are going to dive in how we can prevent the complications in dental implants. Actually, this topic was given to me by Dr. Kemia. So we'll see. Still, I may have to touch upon some of the basics, because without those basics, we cannot talk about the prevention of the dental implant complications. So first we see what is a complication. When it comes to in relation to dental implants, a complication is actually happening secondary. It could be during or after the implant surgery, or once we have delivered the prosthesis. So in definition, that is a complication. But the prevention starts actually from the beginning. So in the prevention, there are a few steps that we need to go ahead during the planning and during the placement, as well as when we design the prosthesis, and also the post-operative care or the maintenance phase. Now let's see this case. Unfortunately, I don't have the clinical photographs here. Now this patient, the main complaint was pus discharging from the gum margin. The patient also having pain. And upon examination, there were bleeding on probing, and also the pus was coming out of the pockets. And on the radiograph, you can see what has happened there. Actually, the patient, even though the dental surgeon who had done the implants had proposed for a bigger implant, or 2 units actually, the patient had wanted to go ahead with just a single unit on the top, because this tooth had to be extracted due to caries. But ultimately, they have ended up in giving 2 implants with the top connected together. And it was really impossible to clean in between these 2 implants. So the prosthetic design had compromised the cleaning here, which had led to the current problem. So such scenarios we can omit or minimize much as possible when we do the proper planning. So let's see what we can do in order to prevent such complications. So first, most important phase is the pre-planning. So we start with the pre-planning. Now, patient assessment, when it comes to patient assessment, it's coming with a package. It's not just the implant per se. You need to assess the overall patient. Medical history, especially the diabetes, because there are evidence to say it's very closely linked with the peri-implant diseases when it comes to the uncontrolled diabetes. And also we need to check the site or the sites involved where we are going to give the implant, retain or supported prosthesis. So in the hard tissue evaluation, either you can go ahead with the 2D and 3D, both is recommended now. And the soft tissue wise, we need to check the quality as well as the quantity around that area. So general guidelines are we need to check the keratinized mucosa, the width. That width is actually coming from the apicocoronal direction, from the mucosa margin to the mucogingival junction. and also the mucosal thickness and the supracrestal tissue height, what is available there. Now, I mentioned about the diabetes because just because the patient is on medication, it doesn't necessarily mean they are under control. So you need to check for the investigations, the latest or the recent investigations, and see whether it's under control actually. Because in the literature, it clearly says when it's under control, especially if the HbA1c is higher than 8%, they are at an increased risk of peri-implant diseases or the which could lead to implant failure. So coming back to the soft tissues, now sometimes we see healthy mucosa, but it's only thin. Generally, we say we need around 2 millimeter. That is the general understanding or the agreement that we have. We need to cover around the implant. But what we can do, whether we can really need an augmentation in that scenario. In the latest evidence, it says there's no very direct or solid evidence to say just doing the augmentation can kind of increase the tissue thickness, which can prevent the peri-implant diseases. But however, if the patient is already having issues in that area, when they clean the area, if it's very next to that mucosa, if the adjacent teeth are having very thin gingiva, and if the patient is complaining of pain or irritation or discomfort during cleaning, they recommend to go ahead with the augmentation. And also about smoking. Now I'm highlighting the diabetes and smoking because those are everywhere. It is kind of reported as very strong associated risk factors. Now smoking has about 1.7 higher chance of implant failure than compared to the non-smokers, because there are certain changes that can happen in relation to the peri-implant mucosa as well as the microorganisms that can affect the vascularization. And also when it comes to the healing phase, the osteoblastic activity could be compromised and the immune response could be compromised. And as I mentioned, the microbiome could be more aggressive in nature or more pathogenic in nature. So we need to assess whether a patient is a current smoker or not. And also the patient education before you start recommending an implant, whether the patient really understands the patient's role, because patient roles start from the day one. When we decide an implant for the patient, we need to educate the patient what is their role, because that plays a big role in for the best outcome. So in the risk management, if the patient is not having enough or a very good glycemic control, we can try to achieve them with the proper medical referrals and so on. Educate the patient about the risks in both scenarios, whether the patient is having uncontrolled diabetes or if the patient is a smoker, we need to educate them about the risk involved. And also if whether there's any parafunctional habits, and if the patient has a history of periodontitis, it's not contraindicated, but there is a risk for peri-implant diseases later on. And we need to also assess the current periodontal health. So the easier way is to carry out a periodontal screening. By doing so, you can get some understanding, but it's important to assess during the when you talk to the patient whether patient had any issues, whether there was a history of periodontitis. Right. Now let's see what we can do while we provide the prosthesis, or the next phase in the surgical phase and the designing phase and so on. Now, when we provide the prosthesis for the implant, we need to first design the prosthesis, because otherwise if we just try to accommodate the implant and then try to design, there could be certain issues. Because these factors, the contour, the angulations, and all that, the prosthetic or the prosthesis design could lead to other complications. Now, let's look at these first two pictures. Let me see whether I can take the, yeah. Now, when you see the first picture is where the implant is more palatal, so the contour is wider there, and also in the other way around. So the issues are, you can see it compromising the plaque control, and also it can, because of the inflammation later on, it can lead to loss of attachment or the peri-implant diseases. And sometimes especially with the buccal placement, it could lead to the mucosal recession, and which could ultimately result aesthetic complications as well as the biological complications, which could be either mucositis or peri-implantitis. And also it's important to assess how deep we can place within the available dimensions. Because one thing we need to make sure the aesthetic we can maintain very well, if it's especially in the aesthetic zone. And also we have to ensure the patient can maintain the plaque control after we have given the prosthesis. So when we consider the buccolingual thickness, we need to decide according to the prosthetic parameters or the prosthesis parameters we are going to deliver. And in the apicocoronal position, we need to see whether there's enough space for the prosthetic components we are designing, and also whether it's a very deep placement where the later on cleaning could be highly compromised. In the mesiodistal distance, whether there's adequate space for the prosthetic components, and also we have to manage with the adjacent teeth or the adjacent implants, and also make sure there's enough space for the plaque control aids to insert. Now, again, this patient had the main complaint the patient had was foot packing. So you can see the angulation of the implant. So we need to, even though there are other complications, but patient had noticed only the foot packing there. So we need to check the angulations and properly design the implant placement, and also make sure you're avoiding the vital structures. And now we have navigation systems which you can easily do the placement or the planning part. And in the literature, they are highly recommending the navigation system compared to the manual system or the manual placement. And also apart from compared to the static and the dynamic, it's the dynamic navigation is more accurate according to the literature. Right. So in the summary of the prosthetic design, coming back to it, we need to plan the prosthesis beforehand, before we place the implants. And we need to decide whether it's single implant or whether, like in this case, whether we can go ahead with the multiple implants. And if we are going ahead with the multiple implants, about the prosthetic design and the diameters. And also it's important to decide on the provisional restorations, or how we are going to provide the provisionalization after placing the implant, because that will help in making the contour of the peri-implant tissues. Now you can see in this photograph the calculi. That's because the patient is unable to clean underneath because of the design here. So we have to make sure the patient can insert all the aids we are going to introduce, At the same time, later on, when we do the maintenance care or when we do the checking around the implant, we should be able to insert the probe around it without having to struggle inserting and checking the problems or the issues with the peri-implant tissues. Another important aspect is designing the emergence profile. So this is important again for the plaque control and also for the aesthetic aspect to avoid the aesthetic complications. And make sure once you get the prosthesis, you need to check whether the prosthesis is good enough to be delivered. Now, these are some histological comparison where the wider emergence profile and a narrower emergence profile. You can see with the wider emergence profile, because the plaque control is highly compromised, the patient is unable to reach this much into the close to the implant surface or the prosthesis, underneath the prosthesis. So there's already the alveolar bone loss which has started. And also, if we cannot access to remove the excess cement, if we feel like we will not be able to efficiently remove the excess cement, it's always better to consider screw retain restoration. Right. So let's see what we can do after giving the implant. Now, all these phases are very or equally important. Starting from the pre-planning or the first discussion with the patient that we are deciding for an implant retain or a supported prosthesis. Throughout, there are each steps which are very much important for the prevention of the complications later on. Now, once we deliver the prosthesis, and even after placing the implant itself, we need to introduce a supportive peri-implant care program. We call it SPC in short form. But the important thing here is you need to customize it. Just introducing something is not going to help the patient. So we can incorporate the plaque control measures, and at regular intervals, you have to get down the patient, check around the area, and also the supra or subgingival biofilm removal, and constant education and motivation of the patient. Now, why we emphasize plaque control this much, the issue is it's very much challenging to remove once a biofilm is established. But we cannot get rid of the 100% remove the planktonic or the circulating microbiota inside the oral cavity, but we can minimize the biofilm formation. So the task or the aim is to minimize the biofilm formation. So once the biofilms are started to form on the implants, the resident microorganisms and also they have a matrix around them, the biofilm, which is a polysaccharide matrix. So that will block even the access of the antimicrobials. Even though now the recommendations are not very much supportive for giving antimicrobials to control the peri-implant conditions or the diseases, but still there is a problem in extreme circumstances. Even the expected outcome will not be there. And because of that, we consider it as a kind of a developing a resistance. So it's easy to manage or control the circulating microbiota with the daily plaque control measures. And also in the evidence show the role of us or the clinicians who's placed in the implant. Because if the patient is not given enough information, if we don't adequately educate the patient about the importance of the maintenance care, the home care, plaque control measures that can lead to the peri-implant diseases. And also the reason for not adhering to the supportive periodontal care program that had been highlighted as a very frequent reason. So that shows the role of us, the clinicians. We need to make sure we educate the patient enough. So these two photographs you can see how fast they can develop on an implant. Same like on our teeth, and also the implant surface has more vulnerability as well. And also because of the nature of the peri-implant tissues, there's more chance for the biofilms to entrap. So you can see even the calculi formation and also the biofilms. And once they surface, it's very difficult to remove. It's easier to remove or control prior to coming to this stage. That's why I'm emphasizing the plaque control measures. Right, we'll talk a little bit about the peri-implant health because that's important to understand the importance of the plaque control as well. Now, it's recommended to carry out a baseline probing after we have given the prosthesis. And also at every clinical examination, you can, depending on the patient's risk factors and also the patient's motivation, plaque control, and so on, you can decide on recall interval. And it's recommended to recheck at every clinical examination, whether to use a plastic probe or metal probe just to check. It's not defined. It's either one you can use, but you have to be very gentle because the tissues are not very strongly adhered around the implant surface like on a healthy tooth. So you have to use a lighter force, and also the diameters are recommended because you cannot use a very larger probes. And for the record keeping, it's good to check circumferentially, like all 6 sides. When we do the comprehensive periodontal evaluation, we check all 6 sides around the tooth. Likewise, it's good to check all sides around an implant. And also check whether there's bleeding on probing. If there is bleeding on probing, it's good to record with the site. And monitor the peri-implant mucosa level, so we can check for the keratinized gingiva and the changes with the healing. And it's recommended to take a baseline radiograph, not the pre-op we already have, but after placing and after completing the remodeling around, it's good to keep a radiograph so we can compare with the consecutive issues. And if we detect there are some changes to the probing depths we have been recording, then it's good to retake the radiographs to assess the bone levels. Right. So a little bit about the peri-implant tissues because it's important to understand certain readings. Now, when you probe compared to a natural tooth, most likely you will get a deeper probing depth. And also it will depend on where you have placed and how you have placed the implant. At the same time, you may have already realized if you have done the probing around an implant, the tissues are not very stiff, even in the healthy peri-implant mucosa. So you have to make sure you are using, as I mentioned earlier, the gentle probing is always encouraged. And there are certain changes why they are not very tightly attached, because mainly the fiber arrangements are coming parallel to the implant surface. But on a natural tooth, we have several fibers going around the tooth encircling, so it has more adherence to the surface. Also, there are changes with the implant, the peri-implant, the junction, how the mucosa connects to the implant surface. But clinically, it's always better to do the probing and check for any bleeding on probing. Those are the key parameters you need to monitor every time. So as I said, depending on where you have placed the implant, the height could differ. And also, it's not like in the natural tooth where we have the periodontal ligament in between the root and the alveolar bone. We have bone to implant connection. So healthy peri-implant tissues will not have any clinical signs of inflammation. And also you will not see any bleeding as well as no suppuration. And the probing depth, if you have been recording the probing depth, you will not see any changes. And also we will not see the bone loss or the bone levels beyond the levels after we have noted at the remodel stage. So that's why you need to keep the baseline information so you can compare later on if you have any doubts of any complication. So peri-implant mucositis, that's the first stage, similar to gingivitis and also which is the reversible stage. It's easy to control than peri-implantitis. So if you see bleeding on probing or suppuration, when you still, if you have done a gentle probing, but you see bleeding on probing or suppuration, it could be with or without probing depth increase. So we cannot really rely on the probing depth per se. And also you need to check for the bone changes, and there shouldn't be any bone level changes if you are to diagnose only for peri-implant mucositis. If there is attachment loss or the bone loss is evident, then it goes to the next level, peri-implantitis. Right. So coming to the most important component in the prevention, the plaque control measures. Now, you may have seen some are available in our local market, some are not, and some have limitations. But it's always good to introduce the patient because sometimes the patient can access for these aids online, or sometimes they can get it down through someone coming from abroad. And also most of the patients are aware about the available plaque control aids. Now, interdental brushes, you can see on the other picture, once it's inserted in between two teeth actually, and this is under electronic microscope, how much plaque or the microorganisms can be taken out. So similarly, if we don't introduce the interdental tools once we have given an implant prosthesis, then there's a high chance there could be inflammation later on. And compared to the floss, the interdental brushes have been shown to be more effective in the interproximal cleaning. At the same time, you need to check for the correct sizes. Usually, we can't rely on just one size because there should be, if it's very loose in between the space they're going to use, it's not effective. So you need to recommend the appropriate size. The limitation is whether we have all the sizes available in our local market. But you can, with the available sizes, you can see what is most appropriate. And if the patient has any form of access to any other interdental brushes, you can recommend depending on the sizes available. So you have to see which ones would be more appropriate for the patient. At least you need to educate them that how to use it. That's important. Just introducing to use this is not going to help them. You have to always demonstrate the patient in the mouth where to use and how to use and when to use. Now, a little bit about the interdental brushes. You can also use them underneath as shown in this photograph, and also in between the sometimes if you have given a single implant as well, then it's the best. Most of the time, that's the best one to introduce. And there are other aids as well. And these are some of the brushes introduced for the implant cleaning. And you can see even in this other brush, you can see it's only 2 lines. So they can clean where the underneath the prosthesis carefully. And also the use of oral irrigators are quite becoming wider and common now. But these are all adjunctive to using a manual or an electric toothbrush. So we cannot replace them by introducing this. But you can, if the patient has the accessibility for these devices, you can always introduce them. The oral irrigators, what they do is they will eject a high pressure stream of water underneath when you direct it. So they can detach any plaque and if there are any food stuff gone inside, and which can create some amount of inflammation. However, in the literature, the removal of the plaque, which has not been very much evidence yet. And also there's another item, we call it superfloss. You can see the superfloss is different from a normal floss because it has a stiff end at the one end, and the middle part, you can see in the middle picture, the middle part is very spongy, and the tail end is like the normal floss. So because there's a stiff end, again, you can use it underneath the pontic. And also, as you can see in the other photograph, and it's easy to pass it through there because it's stiff, not like the normal floss, and use the middle area or the spongy area to clean underneath. So we can recommend with a manual or an electric toothbrush, you can, as appropriately, you can customize and introduce what is best to the patient, whether it's an interdental brush or a single tufted brush. Even though it's not available here in the local market, we can also introduce an alternative made with the kids toothbrush, though it's not the real single tufted brush sizes. And also the superfloss or the water flossers in some instance. So the message is, it's very difficult to recommend what is best for which scenario. You need to always assess the patient's keenness and also the accessibility for these devices, and also how good they will, the manual dexterity and so on, how they can use it inside the mouth, and depending on the prosthetic design, you can decide which is the best. But remember, you have to emphasize again, these are all adjunctive. The supplementary tools are adjunctive tools. So electric brushes, the comparison wise, there are different designs once again, like our manual brushes. The electric brushes, the recommendations are more towards a round shape ones, which has the oscillatory movements. So in comparison, evidence-wise, it doesn't say there's no significant. It says no significant difference. So if the patient has an electric brush, you can recommend it. But again, it's important to demonstrate how to use it, because sometimes I have come across the patients using the electric brush like the manual brush with a lot of movements. So it will compromise the use of the or the advantage of using the electric brush. So you have to always demonstrate how to use it. Now, what about the mouthwashes? We are very keen to recommend mouthwashes, but the latest recommendations are, it has shown very limited adjunctive effect. So we can recommend for short term, but again, we need to educate the patient that these are just the adjunctive and their outcomes are very short term. So we have to monitor the patient, whether they are doing. When the patient is coming for review appointments, you can ask the patient to bring all the devices or the supplementary tools they are using at home and check whether they're actually using them correctly. So it's important. Sometimes they say they are using, but when we check how they are using, that is incorrect. So if they are not using in the correct way, they are not going to be helpful for us and as well as for them. Right. So in summary, when we, if we are to prevent the complications, we have to first do the adequate patient assessment. And the supportive care is very much important. You need to plan a supportive care beforehand, when to get down the patient, and also emphasize that at the beginning. It's important, that's why I said the patient education and make the patient understand the importance of the supportive care is very much important. And we can also get all the adequate precautions, as I explained. You need to do the case analysis and do the planning and do the implant, the placement planning, and also the prosthetic design. And at the same time, we can check back with us whether we have enough clinical skills and experience to handle all the tasks the patient will need, and also whether we can go ahead with more, like in the navigation system, whether we can get some assistance from those available advanced facilities. So we can entertain some questions if you have some of the questions. Even though this is meant for the deep dive, actually we are coming to the basic. That's the other important thing. If you go through the literature also, more emphasis on the very basic things, on the prevention of the complication. When it comes to the peri-implant diseases like peri-implantitis, it's we need to manage the complication, and it's easy to prevent the complication rather managing that complication. So it's important to do the proper planning, and as we discussed today, to do the proper assessment and the planning, and more importantly, emphasize on the maintenance care for the patient. Any questions we can entertain, Dr. Kamian?
Yes, thank you very much, madam. It was a very insightful lecture. And I think like some of the precautions, like most of the precautions that you mentioned is applicable not only when placing implants, but also in the other normal patient management also would be quite helpful. So thank you very much for that.
Yeah.
Not sure whether...
There are two questions on the
Yes,
chat.
by Dr. Binda. Yes.
Yeah. So she's asking spot bleeding versus profuse bleeding around an implant during assessment. Does it make a difference? Well, actually, you need to see for the delayed bleeding also. Now, when I'm not sure about the terminology of profuse bleeding, because the recommendation is to go ahead with the very gentle probing. But even if you do the gentle probing, because as I explained, the tissues are not very stiff like on our gingiva around the tooth. So that's why the probing depth also could be varied. And at the same time, if there's inflammation, if the mucosa is inflamed, there will be a bleeding. But you need to see sometimes just while probing, you may not see, but once you take the probe out, you might see the bleeding. I'm not sure whether I answered the question on the profuse bleeding, but to assess the health, we need to check for any bleeding episode during and after you have taken the probe also out. Also, there was a question on the water flosser. So this is I'll try to get the... spotlight so I can show. Yeah, so this is the tip of the water flosser actually. These are very narrow tips, and the latest water flosser, or we call it oral irrigator as well. Water pick is actually one type of water flosser or the water oral irrigators, and they come like water flosser. That is just a terminology, but oral irrigator is the other name for that. What they do is they will eject water onto the where you are directing the tip. So you can direct the tip. Now, for example, in this prosthesis, you can direct where it's connecting or touching the mucosa around that margin, because it's very difficult to insert any other tool depending on the prosthetic design. So you can use this along the margins to clean that area. I hope that we are using only water for that. That's the other advantage. Laser lock implants. Yeah, I didn't discuss about the implant types here because it's a vast area. If we are going to discuss, it's actually a type of an implant. It's kind of how to explain it. Yeah, it's a type of an implant. I'm not sure about the how we can talk about the complications in relation to that, because different manufacturers will produce this type of implant. At the same time, we don't see much evidence on this aspect when it comes to complications. So that's why I didn't discuss much about different types. And we have to stick to the main types, these, depending on the surface treatments and so on. But again, we need to decide with the available facilities, available implant systems here, and also the type of the prosthesis, because you need to have all the other prosthetic components if you are going to design that prosthesis for the patient. Any other questions?
So the participants can now unmute themselves and even ask the question directly from Madam. Madam, at the very
let me first, I think I didn't explain this. Even these brushes are some not available in our market, but some international market, like this is actually from Taipei. They have different implant brushes. So we can, if the patient has any accessibility, we can recommend them because just because we don't have them in our market, I don't think we can make an excuse for that, because the complications will come back to us, and then again we need to maintain or manage the complication. It's easy to prevent the complication rather than managing these complications. Yeah, Kemia.
Yes, Madam. So at the very beginning of the lecture, you mentioned that you are basically focusing this lecture on the primary prevention aspect, and touching the peri-implantitis would be a different topic based on the secondary prevention.
It's a secondary prevention, yeah.
Right, Madam. So in that case, based on the precautions that you mentioned today, is there a very marked difference between addressing peri-implantitis in the primary and secondary aspect? Is there a much difference?
Sorry, I didn't get the question. Now, if we can emphasize on the primary prevention, we can minimize leading to peri-implant diseases. At the same time, the other complications like the mechanical complications or the other aesthetic complications also we can prevent with the other matters we discuss. So peri-implantitis or peri-implant diseases coming under biological complications. again, all this now, even the prosthetic design, as I explained, it can lead to peri-implant diseases if we don't do the proper planning. So that's the important thing. Did you mean whether they are overlapping or?
Yeah, when it's actually the objective of the question was like in our lecture series, we didn't specifically allocate another lecture on peri-implantitis. So
Right, okay.
after the prosthetic part, we were trying to end the lecture series. But
Okay.
I believe based on the input that we got today, it'll be much better if we have a lecture on peri-implantitis towards the very end. Yeah.
Yeah, that can do. The guidelines were changed actually last year, with the latest evidence in last year. So we can, because most of the practices, what we are doing day to day or what we happen to do day to day is now the evidence say they are not very effective in controlling. Again, they're coming back to basic. That's why I said, even though we started from deep dive, still we have to come to the basics. Because they are now these supplemented tools or the plug control and the maintenance care program is the essential one, which will enhance the longevity of the implant or the prosthesis we have given. So otherwise, if you don't emphasize this, then ultimately there's a chance that we cannot always say it can lead to always peri-implant disease, as it always matters. Like in periodontitis, it matters with the individual risk factors. But it's important to introduce or educate the patient about the risk if they don't maintain. And also from our end, we need to monitor regularly these patients. So if you want, we can come and meet on another day for peri-implantitis management, as well as the mucositis protocol. Mucositis, it's mostly we are going ahead with the plaque control measures, either subgingival or supragingival. But peri-implantitis, depending on the damage or depending on the severity of the problem, there are different steps we need to follow.
So, madam, one last question from my end. Now, you have introduced a lot of methods of interdental, like methods of using like superfloss, interdental brushing. So, when these protocols, like these methods are being introduced to patients, as a clinician, what sort of compliance do you see in the patients? As in, have you seen like them regularly using them, or what sort of behavioral changes when they're adopting these?
Yeah, good question, Kemia. In my experience, if we really emphasize and do one-to-one patient education, like just giving them the general, just giving them like general, okay, brush twice a day, like that, brush or clean this twice a day, that will not be very effective. But if we emphasize the problem and if we show them that's why I said if you can ask the patients to bring the devices and check. It's true, it's time consuming, but in long run it worth, and we can motivate the patient provided we educate them with proper information. I'm not negative on that because I have experienced positive output with the proper education and motivation.
Right, right. So thank you very much for accepting our invitation. With that, we'll end the lecture today. So I think we had a diverse audience today. We had some professors as well, but I believe like most of the dental surgeons who are joining are recently passed out dental surgeons. So they are, of course, like they are your students. So thank you very much for like, I'd like to address the participants to thank them for joining the lecture today. So, madam, once again, I'd like to thank on behalf of the Government Dental Surgeons Association for accepting our invitation and doing a wonderful lecture. So we will actually we'll keep in touch with you for another lecture at the end of the implant lecture series to prevent the secondary prevention methods of dental implants. So thank you very much, madam.
Yeah, sure. Thank you very much, Dr. Kemi, and also Dr. Manjula. I hope I added some light on some directions where to start, because these are basic things, but nowadays we are missing them as well, with the maybe due to time and so many factors. But still, it's worth to emphasize on this, and also for the patient, when we to improve our clinical service or the outcome. This will help. So I hope we can improve together the patient care with the updates, and also constant reminding ourselves the basics are still important. Thank you very much, everyone, for joining. Thank you. Good night.
Thank you.